I'm Rima Ellard with the Foster Care Assessment Program and the Comprehensive Assessment Program at Harborview. And this is our second seminar in this series. We have several partners that we're working with this year to put on the seminars, and I just wanted to thank them briefly. We have Partners for Our Children. We have the UW Court Improvement Training Academy, and we have the UW Public Behavioral Health and Justice Policy. My clinical director, Lucy Berliner, is going to introduce Dr. Chaffin.
Well, I'm really excited to have Mark here. Mark is one of the smartest people in our field. In fact, our field is lucky to have a guy as intellectually sharp as Mark in it. But he's not just a sharp, he's really cool and funny and irreverent and doesn't just study things and write papers to just do it. Almost everything he does is an interesting test of a hypothesis that has relevance to the policies that we are interested in developing in the area of child welfare. And there's not too many people like that. In fact, as far as I know, Mark is it. So luckily, he's still here. Nothing's happened to him. Unlike he had just such a wonderful greeting in Seattle where we went out to a lovely dinner at Serafina's and discovered my car had been stolen when we came out from the... It's always good to bring a guest to the city of Seattle and send them home in a cab. But I just want to mention just a couple of the efforts he's done and how they represent this sort of a different way of approaching the science development in a field. Many of you may be familiar, for example, with the work he's done on children with sexual behavior problems. Now, all of us in child welfare are well aware of the fact that a child having a history of, or a sexual behavior problem is a very serious complication for permanency, for placement stability, for a child's integration into ordinary life. So it's a problem that many of us believe, of course, has been, that the social environment and attitudes are more the problem than the kids themselves. But in order to address this question of how concerned should we be about these kids, Mark and his colleagues published a paper a few years ago, which many of you might be familiar with, in which they followed up a group of kids who were part of a study in which children were randomized to two different types of treatment to see what the rates of repeat misbehavior were. And so they used official records to find out, CPS records, juvenile justice, and for those kids who were old enough, adult criminal records. And the results, by the way, were that overall only about 6% of the kids had misbehaved sexually in the future, even 10 years on. And it had a really great finding from the point of view of treatment, in which the structured cognitive behavioral treatment outperformed the more nonspecific expressive treatment to a clinically significant degree, meaning only 2% of the kids who got this 10 or 12-week intervention repeat misbehaved 10 years later. But Mark didn't stop there in the study. He got a comparison group of kids who had been treated for non-sexual problems, for ADHD, other things, and followed those kids up so that we're not just, and this is one of the things I've learned from Mark about research, you always should ask this question. Anytime anybody gives you a finding from research, you say, well, compared to what? Because that's the whole point. All of this stuff only makes sense if you compare it to something. So they find out that the rate of sexual misbehavior in kids who never had a sexual behavior problem is higher than those kids who got treated for a sexual behavior problem using an evidence-based treatment. Now that's an important implication, that if we give these kids the right kind of treatment that's brief, focused, evidence-based, we actually have to worry less about them than kids who are going off and getting treated for ADHD. Now that would help if people in the child welfare system and foster parents, caseworkers and court commissioners had the point of view, these kids have a behavior problem, but it's a relatively manageable one, and that this whole perception of them that they're dangerous, they're going to attack people, they're all going to grow up and become sex offenders is completely false and has a terrible consequence for the kids. Now, Mark doesn't just stop at doing the research. He goes out and sort of makes it as hard as possible for people to keep on doing things the old bad way. So he has a task force that produces a report that outlines kind of how we ought to be thinking about these kids, what the data are, what the implications should be in terms of not just treatment, but placement decision making, and everyone ought to have this. What's the name of it, Mark? The ATSA task force report?
Yeah, it was a task force.
And it's published in the Journal of Child Maltreatment. Now that is a fantastic package of effort to empirically demonstrate something that has a policy implication, and then take the next step to create a mechanism for people to learn about that and have that available. And he does that sort of routinely with the kinds of things he investigates. Many of you will be familiar, and I assume he's going to probably talk about it today, and his studies with PCIT for families where they've physically abused a child, and which PCIT was compared to usual care to PCIT plus a whole bunch of other things, which is our usual normal way of helping families. Give them a whole bunch of stuff, a solution for every problem, and maybe some solutions for problems they don't even have. Well, that study has the best result we have for any treatment for a child welfare population. The re-referral rate to the system for these kids who got PCIT was the re-referral rate for usual care in this study was about 50%, for PCIT standalone, 20%. Now that's a fantastically impressive result. There's no other studies we have of an intervention for child welfare kids that really has anything like that. But that wasn't all he learned. So that's just one intervention, lasts 16 weeks, and you can have that kind of a result. But he found out another thing, and that will speak to what he's going to talk about today, which is that piling on all these other things in an effort to be overly helpful to the family, all kinds of other services, actually reduced and diluted, apparently, the impact of PCIT to the point where there was not a statistically significant difference in the re-referral rates for usual care or PCIT enhanced. So that's partly a lead up to the talk today, which is the way we go about developing case plans, while very well intentioned, may actually be undermining our ultimate goal. And I'm hoping Mark is going to convince you all of that and how we would be more helpful to these families by being more strategic, more thoughtful, and giving them and targeted. Now, I can't just stop this without mentioning the latest paper I've read, written by Mark, that was the funniest thing. How often do you go and read a scientific journal and actually laugh out loud? Usually it's fall asleep. But I can't even remember the title of it, but it was something to the effect of, what's the title of it, Mark? The Halloween paper.
Halloween one?
You betcha.
Yeah. It was about trick-or-treaters.
Yeah. Well, you see, some people go around saying these wacky things, like sex offenders, there are states, I am not kidding, where sex offenders are not allowed to leave their homes on Halloween. Nor are they allowed to turn the lights on in their house on Halloween, nor are they allowed to open the door or they will be arrested. I think Florida, would that be one? So Mark thought, okay, well that's an empirical. So obviously the idea that Halloween presents a really extra special opportunity for child molesters to grab kids and molest them. So Mark thought, well, that lends itself to empirical evaluation. So they went out and actually found a data set and looked at crimes throughout the whole year, and it will not probably surprise you that there was not an increase in child molest crimes on Halloween. Now, the sad news about this study is it'll have no effect on social policy because it's rational. And social policy doesn't really operate on rational things. But having Mark here is an effort to do that. What we're trying to do is bring rationality and science and knowledge into our practices and policies because we share the goal of making the end result of our intervention with children and families and child welfare one that they end up, at the end of the day, the best they can be as children and families. And if science can inform us on how to do that, we would be foolish not to take advantage of it just because it's intuitive. So Mark is going to persuade you how and why you're going to change your entire outlook on case planning, right?
I'm pleased to be here in Seattle and know the weather in Oklahoma City is not any better than it is here. It's just as bad. It really is only fitting to come to Seattle and be the victim of theft, considering that we just recently stole your basketball team from you. And by the way, they do send their regards. They've lost weight. They've gotten back in shape. They're winning games, and they want us to wish you well. So I'm going to just get started in this with sort of an example, and this is Family X. I've changed a few of the details, but basically this is a real case. We were recently asked to review, for the court, we were asked to review the service plan that had been in place for about a year and a half in this particular case. And this is a rhetorical example. I mean, it's a straw man. This is picking on the weak, which is always a fun thing to do, and because it's just easy to rip this service plan apart with what's wrong with it. But it is unfortunately not an uncommon kind of thing. This was a two-parent family. Both the parents were in their mid-30s. Mother was a homemaker, minimal education. There was a lot of stuff in the case file about her having a personality disorder of some kind. It was really unspecified, unclear what it was. People thought maybe she was psychotic because when she would take her children to the doctor, she would say that she thought maybe she would like to go to medical school, and everybody thought that was terribly unrealistic of her. Father's same age. He was stably employed, low-income job. Family was below the poverty line. And when the case was opened, they dug around. They found out that the father had been in trouble when he was a teenager for sexually abusing a sibling. It was about 18 years ago. And they lived with the paternal grandmother, or were highly supported by the paternal grandmother, who basically kind of made sure that everything sort of stayed together, and the family was relatively dependent upon her for support. There are 4 children, a newborn up to age 6. The oldest child was from a prior relationship, and the other 3 children were from this marriage. And the newborn was medically fragile for a lot of reasons I'm not going to go into. The referral to child welfare was made by a physician because of failure to thrive. This child was not gaining weight. The medical fragility required that there be a lot of extra caregiving involved, which really wasn't being done very well. So basically this was kind of a neglect, little with elements of medical neglect kind of case. You with me on this so far? You've seen these kind of cases in child welfare. I assume everybody has. And there was really no evidence of any other type of maltreatment involved in the case. So that's the case. Here's the service plan. Mother will attend parenting class to learn child discipline skills. So we're going to see a little bit later. This is the single most common service element in service plans in child welfare. If you look at the NISCAW data, which takes a national sample and follows services delivered. This is the single, in fact, it's often in many jurisdictions pretty ubiquitous. It's relatively routine. The father will enroll in and pay for 3 years of sex offender counseling with polygraph monitoring, which a private practice provider was more than delighted to provide. And we calculated it up. It would basically take about 10% of the family's total income to pay for this. The mother will attend non-offending group program for wives of sex offenders. That meant an hour and a half a week. The mother is to demonstrate that she is not dependent upon her husband's mother so that she's not tied to a sex offender economically. So basically, she was being encouraged to break the ties with the paternal grandmother, who was largely supporting the family and was involved in a lot of the caregiving of the children. For the older two children, they were to be sent to individual play therapy, which at the point we reviewed this case had been going on for a year and a half. We asked what the goals of the play therapy were. No one could tell us. All these children, at the time we reviewed the case, had been placed in foster. All 4 children had been in foster care for a year and a half, including the newborn, until there was compliance with the service plan. They were to be in marital counseling, even though the father was ordered out of the home, was currently out of the home. They were to be in marital counseling. The mother was to be in open-ended individual psychotherapy, quote, to deal with her early trauma issues. We're not really clear what those were or how those might be relevant. Counseling for the mother, and this is a direct quote, to clarify what she was thinking when she decided to bring this man, i.e. a sex offender, into her life. Now, bear in mind this offense had happened when he was an adolescent 18 years ago, and there had been no evidence of any recurrence. The children were interviewed multiple times to try to elicit some sort of disclosure and sent to therapy, partly with the goal to elicit some kind of disclosure. In a year and a half, there had been none, and there was no physical evidence, no reports, no allegations, no suspicions otherwise. The mother was mandated to take psychotropic medication. Not clear exactly what kind or what for, but she was mandated to take psychotropic medication. Any physicians, psychiatrists here? Anyone? These things have side effect potentials, typically when psychiatrists weigh the prescribing of psychotropic medication, there is a balancing of risk and benefits involved in the decision to prescribe. This is not a no-risk situation. Father is not allowed to be around the children unsupervised. And in fact, because he had not yet enrolled in sex offender counseling, he was not allowed to be around the children at all for a year and a half. And there was consideration of termination of parental rights because of non-compliance with the service plan. And in fact, it was documented. The mother had said, quote, "Child welfare is trying to break up my marriage," which was interpreted as evidence that she was failing to protect the children. So again, this is a straw man. This is a real case. I'm not making this up. But this is an easy one to pick apart. So when we're thinking about evidence-based case planning and case management and service selection and things like that, this is sort of the example of kind of the problem that we're hoping maybe to correct. So what's wrong with it? Well, I mean, it's easy to pick. And being a child welfare worker is not the easiest job on earth, and so I don't want to pick too much on the people who made this plan, although it was not just the child welfare worker. There was a judge involved and a CASA involved and others. But the first thing we might pick on here is that there was a failure to prioritize and a failure to match. What is the focus here? And initially, the focus in the case is failure to thrive. Caregiving skills, basic caregiving resources. Is that the focus, or is everything the focus? Everything in the family somehow became the focus, and in many ways, the eye got taken off the ball in this. The ball being the failure to thrive and the child's medical fragility and the caregiving needs of that newborn. Too many services. I added it up. Conservatively, the parents would be participating in over 16 hours a week of services in order to comply with this particular service plan, which of course means you have to quit your job, or the other alternative is to get a divorce, and then half the service plan goes away. The services arguably are the wrong services. They're not services that actually address a problem that we know that exists. The other issue, I think, is a little more one that's a matter of policy or social politics or some other kind of thing like that. And that is, perhaps there's a failure to discriminate between what is properly a child welfare concern and what is a private personal concern. For example, being mandated into treatment to deal with your early trauma issues may have very little relevance to what was actually the child welfare concern, which was that the medical needs of this medically fragile newborn were being adequately met. And really none of these services clearly were evidence-based, not only for the problem that we would think was the focus, the ball that you should have had your eye on, but none of them were evidence-based pretty much for anything. So easy to pick on. Who made this plan? Well, it was a lot of people. And so this was not one individual's plan. There was a child welfare worker. There was a senior supervisor involved in making the plan. There was a CASA worker, very nice lady, clueless, but well-meaning, and, trying to learn, trying to do well, really concerned about these kids. There was a judge. It's a judge we've known and dealt with for years. He's a good guy. He's generally pretty sensible. He's not a fool. He's a good guy. So I think we have to ask not just simply the questions about, were these people idiots or what? Because they weren't. But maybe what were some of the sources of their reasoning in this? Why would a case plan like this be formed for a case like this that's really so obviously a mismatch? Was it defensive practice? We certainly see this in medicine all the time, that people do all kinds of things, not because they really think they're needed, but because they're afraid if something goes wrong, they'll get nailed because they didn't do them. And I think that happens in child welfare a lot too. People practice defensively. We've done some preliminary interviews of frontline child welfare workers and supervisors in our county about how they form case plans. And one of the things we commonly hear is that they are afraid of two things. One, they're afraid that if they leave something out, if they leave out one of, the worst words, the worst phrase anyone can hear in this world is any sentence that begins with the words, what about? Well, what about the history? Well, what about this? And they're terribly afraid that someone is going to come around with a what about question about the case, and particularly if it's a judge or someone else, they're going to get yelled at. So there's a lot of, one of the sources that at least workers tell us about defensive practices is they're afraid of what will happen potentially to them if they don't include everything. The other thing that we hear is that they're very concerned about some sort of exposure publicly in the media or before the legislature or someplace else, like that if you have a case that goes wrong, and you always will, that someone's going to come around very publicly and say, well, what about this? Why was it? Now just imagine in this failure to thrive case, if a year later it's discovered that this father was badly sexually assaulting these young children. And it came out that child welfare had been involved in the case. And it got into the newspapers. Why didn't child welfare knew this man had a history? Why did they ever let those children go back to that home? Why didn't they do something about it? And people would be up in arms. So these are the things that at least in our sort of interviews and focus groups with child welfare workers that we've been told a lot that they worry about. They worry essentially that if they don't do it, that something very negative potentially could happen with them. The other possible thing is current standards. We're going to talk about those a little bit, and sort of a general set of operative ideologies about service planning. So what are some of those ideologies? Well, Lucy and I are on a task, yet another task force, this one focused on evidence-based case management as soon as we figure out what in the heck that is. But as part of that, I've kind of begun reviewing a lot of federal standards, Child and Family Services Review standards. For those of you who know what Child and Family Services Review is, I'm sorry for the post-traumatic stress disorder trigger that probably is constituted for you. It's just, what a nightmare those things are. So I've gotten all these documents. I can't claim that I've read every word of them, but what I do, this being the electronic age, is I type in a couple of keywords and I search for them throughout these documents. And so one of the keywords I typed in was comprehensive, just to see how many times the word comprehensive appeared in some of these standards. And after getting to about 30 or 40 in the first few pages, I just quit. The other kind of, you hear a lot of other kinds of things, and I'll tell you some other terms I've come up with, but holistic, family-centered focus are things that are really pervasive ideologies in child welfare. These are the words that people use to describe what is considered good and good practice. More is better is really one of the operative ideologies. And the other thing I think we see a fair amount of is that underlying problems are actually more important than what are characterized as surface problems, which are usually the problems that actually bring people in the first place. And this is the what about. And then there's the mission creep, which I think happens in virtually every field. Anybody here a trained psychoanalyst? Probably not. Everybody knows about psychoanalysis and Sigmund Freud, right? Do you know that when Sigmund Freud first developed as a young man, back before he had the beard and lost part of his jaw and from smoking too many cigars and all that kind of thing, that back before then when he was a young man that psychoanalysis took about 2 weeks? And then it sort of morphed, particularly when it came to the US. It sort of morphed into this long-term, character analysis as opposed to, it got out of the business of sort of trying to relieve people of their symptoms and got into this business of correcting deep character structure and other kinds of things. Like, well, whether that worked or not, we're not going to get into. But there was mission creep. In psychoanalysis, there's mission creep in virtually almost all kinds of clinical practices and survey and stuff you tend to examine. I do some work with primary care physicians, and they'll tell you a lot about mission creep and about basically every new thing that comes down the pike that they're asked to fix and inquire into, and on and on and on. And that basically, if you were a primary care physician and you inquired into all the things that every advocacy group wants you to inquire into, you pretty much would spend your entire allotted time and then some in every client visit, every patient visit, simply inquiring into all of the things that people think are important and may be important. So that was the other kind of, I think, factor that we identified in this. Child and Family Services Review, I've mentioned the comprehensive services. This is a quote from one of the documents. The assumption that, the foundational assumption that is made in the federal regulations is, quote, the most fundamental needs of children, such as needs for nurturing, belonging, and safety. Now, safety's a big one for child welfare. Cannot be addressed effectively without attending to the entire family's needs, everything. And this is enshrined in policy. So even if we were to figure out tomorrow what case management is, I doubt that we would be able to implement it in light of current federal policy structure. We probably would get states in trouble. But I think maybe we can make some movement on that. In short, kind of the operative ideology that I think runs through lots of service planning strategies is one of a program or a service for every problem. And this is part of what's viewed as good practice. The other kind of operative ideology that I think plays into this is movements that we've seen over the past couple of decades towards these kinds of coordinated, multi-provider, multi-player, lots of cooks in the kitchen, coordinated service systems. And depending upon the system, these may go under different names, but in many ways, a lot of the fundamental practices, these are case management systems. These are not treatments, by the way. But you've all heard of these. You've heard of wraparound. You've heard of systems of care. You've heard of family group decision making. And there's lots of others. These are basically processes in which there are lots of meetings, multiple players show up. There's typically a facilitator or coordinator. The engagement and participation of the family in the process is encouraged to some degree, may happen to a lesser degree than it's actually encouraged to happen. But they emphasize really increasing access to service and increasing the dose of service and increasing engagement in service and buy-in into services. And by the way, they're relatively effective at achieving a lot of these kinds of things. What they're not effective at doing, unfortunately, is reliably increasing case outcomes. So again, the findings in the research on these particular systems vary, but I think it's, if you look across the studies, it's reasonably clear that they increase the dose of services and the volume of services received, and of course they thereby increase the amount of money that's expended in the services, and they improve consumer engagement. Consumer satisfaction goes up, buy-in to services, compliance with services goes up, but they don't necessarily yield better outcomes. And this has been documented in probably the two largest studies that everybody's familiar with are the Fort Bragg study and the Stark County study in mental health systems. So why? This is a somewhat counterintuitive finding. If you improve access to services, people get more services from more providers at a higher dose, and they're happier with the services they receive. Why doesn't that improve outcomes? Well, there's at least a couple of possibilities, one of which has been widely discussed, and I think at this point is reasonably accepted, and that is that maybe the services that are being managed or coordinated were not terribly effective. Maybe evidence-based practices were not being used very well in that particular community. And you can integrate and coordinate and increase dosage of ineffective services, and it doesn't matter all that much for outcomes because they're ineffective services. This is a widely considered possibility, and so one of the recent initiatives within systems of care and other types of management models like this is to link them up with evidence-based practices, and hopefully that would improve the outcomes. The other possibility, which we may want to consider that's not been widely considered, is that maybe simply poly-services or the stacking of services has an associated downside to it. Now, this is possibly not a bad analogy, but certainly in psychiatry a generation ago, there were some similar concerns raised about what was called polypharmacy, which was the prescribing of a vast number of different classes of medications, and you'd see people on whole different clusters and classes of medications. That's to some extent making a comeback a little bit. Polypharmacy is not quite the bad word it used to be. But it's making a comeback a little bit. But essentially, a generation ago, there was a shift in prescribing of psychotropic medication from many different, the whole cocktails of different medications to sticking with a single medication or a single class or group of medications because there were all kinds of problems with polypharmacy. But it's possible that in our field we may have something similar. I'm going to present some data on that or talk about some data on that because there's actually been a fair amount of study of that, particularly in the area of parenting programs over the years, that it may have an associated downside. And maybe a lot of the benefits that things like family group decision-making or systems of care or wraparound, maybe a lot of the real benefits that come from these types of case management structures to a certain extent get offset by the fact that you're overwhelming people or you're mixing in compatible services, no matter how well they're coordinated, that it may have sort of an iatrogenic component to it. Then there's lots of other kinds of things that go into, I think, the operative ideologies of case management and child welfare. I did searches for a lot of these particular terms too and gave up after a short while because they were literally 3 or 4 in every paragraph. You guys have heard of these? Strengths-based, family-focused, child-centered. These are familiar terms to you. I've worked with people in child welfare for years. I've never been a child welfare worker, but I've worked with people in child welfare for years, and a lot of them are really smart people, and some of them have been, directors of state, like Charles Wilson has been doing this forever, has been director of a state child welfare system, and head of a big national task force on some of this kind of thing. And I've asked them to try to, could you really define for me exactly when we talk about being strengths-based, family-focused, and child-centered, what does that exactly mean that you do? No one's ever been able to give me a clear answer to this. As clear as it comes is, well, it's just sort of an attitude. It's sort of a value system. It's not really anything clear that you do. It's really hard to know if these kinds of things, these sort of operative ideologies, actually deliver benefits to families and children, because they're incredibly difficult to test. They're difficult to operationalize. They're difficult to basically say, these are the kinds of procedures that we use. Yet if you look in the systems of care literature, the family group decision-making literature, these terms, we're strengths-based, we're culturally competent, we're culturally relevant, we're family-focused, we're all these kinds of things, are peppered throughout. And yet it's not really clear. So I think it's, and I don't mean to badmouth them, that they're bad things. I just think they're things, they're part of the operative ideologies of case management, but as near as I can tell, what they actually mean in terms of what you do is probably subject to considerable individual interpretation. The individual workers interpret what that means. The other thing that we hear a lot in the case management, case planning literature is that service plans must be individualized. They should be highly individualized and responsive to individual needs. This is something of a paradox because when we've reviewed child welfare service plans, turns out they look a lot alike. And again, this is an untested assumption. Do highly individualized service plans actually yield better outcomes than a standard protocol or 2 or 3 protocols that we would, funnel people into 2 or 3 basic protocols depending on some rather broad characteristics? Do highly individualized plans really work better? If you look at the evidence-based treatment outcome literature, you probably wouldn't be optimistic about this. I think there's a good chance they work better. But what is the most highly individualized service approach out there? Well, it's what people euphemistically call standard community care, which is very ad hoc, very individualized, completely tailored, involves not a lot of guiding structures or fixed types of protocols or programs that people go through. It's usually something that's rather idiosyncratic to that particular provider and that particular client. And anyone who wants to look at the literature on standard community care will not come away feeling very good about the client outcomes that get generated. So we don't know. I think it's largely an untested assumption. May be true. So I think that's sort of kind of the guiding ideologies and the guiding principles that we see underlying a lot of different child welfare service plans. And I want to talk a little bit now about this concept of evidence-based case management. And let me preface this by saying that evidence-based case management is, well, it's actually a term that as near as I can tell, Ben Saunders may have invented this term about a year or so ago. And we've picked it up in a task force and actually one of the first jobs of the task force is to define what in the heck it means. But it's very much a work in progress. So what I'm going to talk about are sort of some general principles that I think may be useful to incorporate into a more evidence-based approach to case management. But it is a work in progress. It's the application of what we've learned from outcome research applied to how individual case plans are developed. And in that sense, what we're going to be talking about is a little bit more than simply favoring well-supported services and programs over those that are less well-supported. So it's something that's broader than that. And in the discussion here, what I'm going to focus on is psychosocial services, not all services that child welfare delivers. Child welfare delivers a lot of services, beginning with foster care, for example, but lots of other services that involve helping families meet concrete needs, help with housing, other kinds of things like that. I'm not going to be talking about those kinds of things, but don't forget about them. I'm not sure you could you could probably come up with the best evidence-based case plan with the highest quality evidence-based services with a family that was homeless and starving to death, and you probably wouldn't get very far. So the kind of concrete services, the basic safety services like shelter and foster care and things like that that child welfare provides are not what I'm going to be talking about here. I'm just going to assume that those are in the picture. And now we're talking about more rehabilitative types of services, psychosocial services that are being offered. So I'm going to look at a couple of things that we think maybe we know at this point about evidence-based treatments, about what things tend to be associated with service benefit, some of the dose literature, and some of the literature about matching, and focus on child welfare outcomes. One of the problems in talking about lessons learned from evidence-based treatments is that when we call something an evidence-based treatment, the only thing we're talking about is the evidence supporting the effectiveness of the treatment. We're not talking about, when we talk about the evidence-based practice movement, the evidence-based treatment movement, we're relatively agnostic about what the treatment actually is. The question in evidence-based treatment is, does it work or not? Can we demonstrate in some rigorous way that the treatment delivers its purported benefits? So it's purely about how the treatment is evaluated and the strength of evidence supporting its benefit. It's not about the content of the treatment. Now, this is, by the way, this is what makes evidence-based treatment a pretty radical departure from, I think, the way we've always operated. Typically in psychosocial services, by the way we've always operated is, tell me what the program does. Tell me what the program's like. Tell me what the program believes. Tell me, how you work with people and other kinds of things like that. We then resonate that with our own personal and professional value system and come to a decision about whether the program is good. Well, we believe in empowering families to meet their own needs. Boy, that sounds good to me. So this must be a good program. Or we work with children on their individual trauma issues. Well, that sounds great. I'm really interested and I really believe in helping children with trauma issues. So this is a good program. I'm going to refer clients there. This is typically the way I think we've evaluated treatments historically in the psychosocial fields. We've evaluated the sense to which they resonate with our personal values and theories and ideologies about services and about people and about values and about human beings. And if they resonate, then we think it's a good service and we like to refer people there. What's radical about the evidence-based practice perspective is that, at least in theory, none of that's supposed to matter too much. What matters is, can we rigorously, objectively document that this delivers the intended benefits to clients? So evidence-based treatment is purely about evaluation and outcomes. It's not about the means or the methods by which you get there. But that's the caveat. But we've been doing this for a while in mental health practice, in psychosocial services, and at this point we have a rather rapidly growing crop of well-supported or reasonably supported evidence-based models and practices. And we have enough of them that people have begun to do meta-analyses of the studies, which is where you combine the results of various studies together. Folks have begun to look at what are the common elements that run through the better supported treatments that are out there. And what we see is that basically there are some common threads that tend to run through the better supported treatments. Now, are these threads really the critical elements in what makes services work? Well, maybe. It's probably it's not a bad assumption to make, but it may not necessarily be true. It may just simply be that these common threads represent what people are currently researching. So for example, in a lot of the research on treatment for child behavior problems, really the biggest group of best supported practices are parent training programs. Particularly the behavioral parent training programs are the group that really has the best supportive data currently. Well, is this because certain kinds of parent skills really are the best way to reduce behavior problems? Or is it because those are simply the programs that are doing the evaluation and the testing and generating the outcome research data currently? I don't know that we can say. There have been some studies that have compared different types of models and programs, comparative outcome studies, and I think those play into this to a certain extent. But the assumption I'm going to make is that maybe some of the common threads that we see running through evidence-based treatments can also give us some information about how we need to be planning services and organizing services. And this is both about what the elements are and about the process of it. So, why do evidence-based treatments work? Why does the current group of well-supported treatments, why do they seem to work, and why do they seem to work better than alternatives? Here's some reasons I think are poorly supported. I don't think that, and you hear these often as objections to evidence-based practice, and I think most of these actually are pretty readily refuted by the available data currently. Some people will say evidence-based treatments work because in these research studies, people cherry pick and only pick the simplest, easiest, least complex, least multi-problem kinds of families. I'm going to show you some data from some of our randomized trials where we picked absolutely the worst bottom-end child welfare cases that we could possibly find. All the children removed to foster care, typically on average on their 7th trip through the child welfare system. Most of the families well below the poverty line, lots of depression, addiction, everything else under the sun. I think if you look in the child welfare field, this may be something you see in some areas, treatment of depression, for example. But I don't think you see this in the research that's been done in child welfare, child abuse, or parenting, or family preservation types of interventions. The other objection is, well, it's all that the therapists that were used in these studies are all ringers. So it's all therapist effects, and that people were basically picking better therapists in the evidence-based condition than they were in the comparison condition. And that's, I think, been fairly well refuted at this point, considering that typically most of the research is done often using the least experienced therapists, like graduate students, often get used in the evidence-based treatment. That only developers themselves get good results. Nobody else can get the results. So basically, if you develop the evidence-based model, you can get results, but if other people try to take that model and use it and replicate it, they can't get results. I think that's been, to some extent that may be true, but I think in most of the child welfare types of programs that we're going to be talking about, that's really not the case in most of the research. In fact, much of the research in child welfare has been done with borrowed models. So for example, the research that's being done on the incredible years with child welfare is not being done by the developer of that program, it's being done by another group. Most of the research that's been done on PCIT with child welfare populations has not been done by the developer, it's been done by another group. The other thing you hear is that evidence-based treatments only work with non-minority clients or with people from non-majority cultures. That's really the only people that it will work with. And this is something that's been examined empirically. It's been studied in meta-analyses across different studies. It's been studied in the delinquency literature and others. And typically, surprisingly, what folks find is that most, on the whole, evidence-based treatments actually tend to deliver slightly greater benefit for minority populations than they do for non-minority. So it's not only not supported, it appears that actually the opposite is true. What are some of the things that we tend to see cutting across the current group of evidence-based treatments that are currently identified, particularly those that are relevant to child welfare kinds of things? And I think one of the first things we see is that by and large, the vast majority of evidence-based treatments are short-term. Now, I was initially trained as a psychodynamic therapist way back when in the day, and where a trial of psychotherapy was 6 months, and full psychotherapy was anywhere from 3 to 5 years. That was my initial training. I've kind of come a ways over the years. Most of the evidence-based treatments we currently see run anywhere from 12 to 20 sessions. And typically at that point, folks are pretty well done if they go through that. And that is generally, depending on the community you live in, that is not the rule. Typically services, the plan of them is far longer. Most evidence-based treatments are relatively short-term. They tend, by and large, to be behavioral to some extent, behavioral or cognitive behavioral. But particularly for those that are relevant to child welfare, they have a clear behavioral skill focused. In other words, what you see less of, for example, I do a lot of work in the parenting area. We do, in most of the practices, most of the models that I'm working with, we spend no time talking about, how you were abused physically as a child and how that impacts your current parenting behavior with your own children. How much time do we devote to that in some of the evidence-based practice models? The answer is 0. No, and I'm going to show you some data here in a little bit where we contrast this very, very simple, basic behavioral skill model with a much more in-depth, understanding your own childhood, and I'll show you the outcomes in terms of child welfare recidivism on some of that. But basically, they're very behavioral skill oriented. They typically use a number of approaches that the therapist does: modeling, direct practice of the skill, not talking about the skill, not talking about parenting, but directly doing the skill, and then feedback and correction on the skill, reinforcement of the skill. One of the other themes that you see across some of the evidence-based literature is that a lot of the more in-depth types of approaches, not only do they not do as well, but they have significantly higher rates of negative effects. One area where this, by the way, has been documented is in early parent-child bonding and attachment interventions. The more in-depth, the longer term the intervention, the more likely there are actually negative impacts. The more clear, specific, behavioral skill oriented that they are, the better the impacts on things like attachment and parenting. The other thing, I didn't put it down, but the other thing I think you commonly see is that the extent to which all the caregivers in the family are involved typically is something that runs across the more strongly supported interventions. So involving fathers as well as mothers. It's usually a little trickier to get fathers in child welfare services, but the extent to which fathers are involved in some of these. And actually what we find is that what we found in our research is that the trick is not keeping fathers involved. The trick is getting fathers involved. Once we get them engaged, and they tend to engage, by the way, men, us being men, we tend to engage pretty well with something that has a plan and is behavioral skill oriented and has we're going to do this for a relatively short number of sessions. We're going to learn these skills and demonstrate these skills. It's just like fixing a motorcycle, folks. We connect with that kind of, it's on the Y chromosome somewhere, I don't know where, but we connect with that. But getting fathers involved is another thing that runs across a lot of these. And once you get them involved, they tend to stay involved. The other thing you see running across these is that they're relatively structured. By the way, this is why people like evidence-based treatments. It's also why they hate them. So we've done surveys of a lot, and some of our uptake research, we do focus groups and interviews and web-based surveys with our colleague Greg Ahrens down in San Diego of frontline providers who are picking up evidence-based models. And the number one thing they love about the model is it's structured. I'm going in, I have a plan, I know what I'm doing, I know what the goals are, I have my materials, it's all set, I'm ready to go. There's no more this wandering around in the dark trying to figure things out kind of stuff. I really like that. And what's the thing you hate most about the treatment? Well, I hate the structure. It's so limiting. So this is sort of a mixed thing. People love it and they hate it. But they are more structured. There's no question about it. The current crop of evidence-based treatments are far more structured. They're planned and active. And in that sense, they do require a little bit more out of the providers. The providers are far more active and directive in the sessions as opposed to being passive and reflective. And they do require planning. You can't just say, oh, I've got an appointment, I'm going to go do it, and we'll see how it goes, we'll see how it develops. You actually have to go in with a plan for what you're doing that particular session. And they tend to be more focused. And if this, by the way, I think is one of the watchwords we're going to pick up for evidence-based case management. That in evidence-based case management, as we're beginning to conceptualize it, the value is much more on focus rather than on being comprehensive. It is on picking a focus and serving that focus really well, as opposed to trying to serve everything and provide a program for every problem. And I think really most of the current crop of evidence-based treatments kind of follow the KISS. You guys here in Washington, we know this in Oklahoma. You guys know the KISS principle here in Washington, right? Keep it simple, stupid. Really, in all honesty, none of these evidence-based models, none of these things are rocket science. These are all folks, these are things we teach graduate students how to deliver. How hard can it be? Well, what are the elements? And by elements, I mean these are actually the things that people do in evidence-based. So for example, in parenting treatment, an element would be like teaching parents to ignore minor misbehavior, teaching parents to praise positive behavior, teaching parents to use a structured timeout procedure as a consequence for negative behavior, teaching parents how to use reflections in their interactions with their children. These are things like elements. And typically, if you look at most of the evidence-based treatments that are out there, as I've mentioned, none of these things are they're not only not rocket science, they're not even new. Most of the things that are in evidence-based treatment models are very relatively, there's no magic, there's no new innovation in the elements themselves. If you look at them, actually, they have fewer elements. It's not that they've added more elements or they really are totally comprehensive. For example, I do a lot of work with parent-child interaction therapy, which I know has gotten to be kind of a big thing here in Washington, which is a good thing. But in parent-child interaction therapy, you can count on two hands pretty much the number of skills we're trying to teach parents how to use. The number of elements in these is actually relatively small, and none of them are really magic, new, brilliant elements. They're the same parenting elements that run through all behavioral parent training programs. If you pick up the manuals for PCIT or Incredible Years or parent management training or the Forehand and McMahon model or Triple P or any of the other kind of models and you read through them, they're talking about the same things. They're talking about the same kinds of parenting skills. What's different is the way that they're delivered, the structure, and some other things like that. So the elements really are not novel, but they're much more structured, they're in a somewhat different package, and they're delivered typically in a much more focused and effective type of manner. In fact, Lucy and I spent a lot of time talking about the work of a guy formerly out of Hawaii, Bruce Chorpita. I don't know if any of you are familiar with his literature. He's essentially made a living at looking at evidence-based treatments and distilling down what are the core practice elements in these treatments, and then essentially saying, well, now let's just have people in a systematic way deliver these particular elements matched or tailored to a particular case. And I think at this point, people are fairly optimistic about how the outcomes are going to look from some of that work. So the elements are not new. They tend to be fewer in number than in usual care. If you look at the treatment plans and what's actually done and what the goals are in most evidence-based treatments, they're relatively more modest in some ways than what standard care is, where people are often, they fall into the mission creep and the whatabouts and feel like, one of the things we did in some of our implementation work was before we would begin implementing an evidence-based model, we did this with a child welfare home visiting program. A lot of our faculty would go out on the home visits and directly observe the home visits. And we observed, about 125, 150 home visits that were done by folks in usual care. And people would ask the home visitor, okay, so what's the plan for today? And they typically had a plan, which was good. They had a plan. When they got there, what happened? Well, there was chaos and it was a mess, and there was the CAL, the crisis of the week. And typically, it was very rare that what was actually planned for the session was actually delivered in the session because of the chaos and the cry. So, often what evidence-based treatments do is not that they give you entirely different things to do or different elements, but they help keep you structured and focused and on track with those elements. The other thing I think we sometimes see is, and I think this is to some extent a cross-cutting feature in the evidence-based treatment research. Less is sometimes, and in fact, less is often more. That is not to say that 0 is the best, or that there's no such thing as sufficiency, or that there doesn't have to be a certain critical minimum. But less is often more. And there have been a number of areas where this is proving out to be true, and I think one of the ones where it's most relevant to child welfare is in the parenting literature. At this point, there's been a meta-analysis of a substantial number of studies that's fairly clearly demonstrated that when additional services, particularly, by the way, mental health services, are added on top of parenting interventions, that the uptake of the parenting skills is reduced. This, by the way, not only occurs when that is a naturalistic thing where, like, people with more problems are the ones who get the mental health services, but also when it's randomized. And in one of our studies, we actually randomized people to get additional services if they needed them, or just to get the parenting model. And, as Lucy mentioned, the lower recidivism was in the group that got only the parenting model. You want to know what else was interesting? I mean, we randomized parents who were depressed to a, not suicidally major depressive disorder depressed, but at least a 19 on the Beck Depression Inventory. Randomized them to get either additional individual therapy and SSRIs in addition to their parenting program, or just the parenting program. Guess which group had the largest improvement in depression? Contrary to our prediction, we predicted that the SSRIs and therapy, which is sort of the standard of care for depression, would do better when that was added to parenting than just parenting alone. The group that got the greatest improvement in depression was the group that got parenting training alone. So it's not just simply that sometimes less is more for the intended target, but sometimes less is more broadly. So they not only had lower recidivism, they had a greater rate of learning parenting skills, they had a trend towards a greater rate of learning parenting skills, but they also had slightly better improvement on their depression. And we're not entirely sure why this is. It probably has something to do with loss of focus. But it's fairly clear, and it's also been replicated in a meta-analysis of parenting programs. So it wasn't just true in our particular study, but this is a theme that runs across the studies, that less is sometimes more. The other area where this is true is in attachment interventions, in parent-child bonding and early attachment, which is pretty relevant to a lot of child neglect kinds of cases, where we see that often the more in-depth and the more comprehensive, multimodal additional services typically do worse. I'm going to show you some new data here in a minute from some home visiting programs that's going to show basically the same kind of thing. This is also basically beginning to look true to some extent in exposure-based trauma therapy for children. That this was a randomized trial. I don't think this is published yet, is it, Lucy? No, it's not published yet, but since we kind of know the folks who did it and we've chatted about it. But it's actually becoming clear that the lower dose treatment actually maybe did a little better than the higher dose treatment in reducing trauma symptoms. So, focus seems to be important. I'm not saying that, less is more all the way down to 0, but certainly I think more than we would have suspected from our work in the past. The more focused, brief, concise types of interventions typically do a little bit better, and this tends to be true in prevention. This tends to be true with clinical cases, and this tends often to be true with multi-problem cases. We do not yet scientifically understand the parameters of this phenomenon. In other words, we don't understand exactly where sufficiency lies and when service dose becomes too much. But it's very clear that the point at which it becomes too much is much lower than we previously thought. So for example, we don't understand whether if there's a serious substance abuse problem, if adding substance abuse treatment is a necessary prerequisite, whether it's an option, or whether it begins to impair effect. So we're not at that level of specificity. But with parenting programs, attachment interventions, and trauma interventions, it's fairly clear that there is a less is more phenomenon. Sometimes less is just as good. In some of the studies we've done of home visiting programs, the program that we were studying was structured to last for 6 months of home visiting. In some cases, people were able to get extended beyond that for up to a year or a year and a half of home visiting service. And we looked at things like the likelihood of the children being reunified into the home, the likelihood of recidivism, the likelihood of improvement on measures, other kinds of things like that. And basically what we find is that pretty much if people have not gotten substantially better, have not gotten to a point where they can have their children back home, if that hasn't happened within 6 months, the likelihood that it's going to happen by extending out to a year or a year and a half becomes increasingly small as you go on. So that if you plot the dose of service and the benefit of service, it's a curve that looks like that. And it levels out at the top, and it levels out relatively quickly. When we've done studies on PCIT, and this is a study that we just published recently, and we looked at the rates at which parents' interactions with their children changed over the course of treatment. Pretty much all of the improvement in parent-child interactions occurred within the first few sessions of the intervention. Now, again, this is a very focused intervention that gets right down to business. We don't spend time, building this big rapport and exploring stuff and stuff like that. We go right to the parenting skills in this particular intervention model. And that may be why, but typically most of the change occurred in the first few sessions. That doesn't mean that the other sessions may not be important for cementing that in some kind of way, but typically the change you see is early on. So less is sometimes just as good, and there is a dose-benefit curve. The other thing we see about evidence-based treatment traits is that they tend to be assessment-driven. In that sense, in research we call these inclusion criteria, that there is a match between the symptoms and the desired outcome, and that basically the clients who are included in the treatment are those who are assessed as needing the outcomes that the treatment delivers. So for example, to go back to our initial straw man of the service plan that was set up, the service plan was set up included a parenting program that was targeted at improving child discipline skills. But there was not necessarily a child behavior problem or a child discipline problem that was identified. It was a medical care problem. So typically in the evidence-based literature, we wouldn't give that treatment to that individual. The other thing about evidence-based treatments is that they typically target intermediate factors or risk factors that are known to be directly related to the ultimate outcome. In other words, they target things that are known to be risk factors or mediators. They're usually small in number. They don't just simply have a logic model. You can have a logic model for any. I once talked to someone, just not recently, who had a logic model that getting parents to quit smoking cigarettes would prevent child abuse. You see, because secondhand smoke is known to cause some neurological problems with kids, which may cause behavior problems, which may lead to some harsh parenting, which may lead to child abuse. Therefore, if we can get mothers to quit smoking cigarettes, they won't be abusing their children. So that's a logic model. Now, I'm a little skeptical of that logic model. That would actually pan out that kind of way. But anybody can have a logic model for anything. But what evidence-based treatments the current crop tend to focus on are things that are well known to be risk factors. For example is something like MST or functional family therapy, which focus on some known risk factors for delinquency, things like parental monitoring and supervision, affiliation with delinquent peers, engagement with school. These are things that are known to be big risk factors and intermediate and mediators for delinquent behavior in adolescents. So these treatments don't focus on everything. They focus on what are known to be the salient risk factors or mediators. This is what I think is the #1 hallmark of the current crop of evidence-based treatments. It's not so much the elements in them, because they're fewer. They tend to be more carefully selected. But the thing that really is the hallmark of them is extensive quality control. Typically, providers who deliver the current crop of EBTs must demonstrate specific competencies with the evidence-based treatment. They often involve things like direct practice observation, feedback, skill monitoring, and things like that to develop not just fidelity to the model, but competency with the model, a high level of skill with the model. And possibly, unfortunately, in psychosocial services, quality control has kind of come to be synonymous with the inking or the incorporating of evidence-based treatments, and that you sometimes have to buy in to some outside training organization, or you have to get licensed to do the particular evidence-based practice, or something else like this, which means you have to pay money. And often there's no money coming back from that kind of investment, so it's very difficult with the incorporating of these things to actually buy that level of quality control that comes with it. This is something, by the way, that I think a lot of systems are struggling with, about how do we localize our quality control. For example, if we're going to do parent-child interaction therapy, thanks. How do we build local expertise to do training in that model? Because people don't come out of graduate school, in most places, already trained to do it. How do we build the local expertise to do the training, to do the monitoring, to keep the quality high, to keep the fidelity high in the model? And because we don't want to be tied to some external institute or place we're having to pay a large amount of money. And often it can be, I think, what is it with MST to get an agency trained up and licensed, about $50,000, something like that. It's a lot of money. So again, I think one of the things in the literature and in the practice, what we're currently struggling with is how do we localize that and make it more cost efficient and not have practitioners tied to some external institute indefinitely for a high amount of money to make this happen. But quality control really, I think, is the hallmark of a lot of these evidence-based practices. A couple of other things. I'm going to show you a little bit of, this is an article we have currently in review. And it goes to the whole question of how comprehensive do you need to be. One of the things that you see is, to some extent, with most treatment, with evidence-based models, that there is a rising tide of benefit that lifts multiple boats. And I talked about this earlier with the improvement of depression, of parental depression in parents who are receiving PCIT, which, by the way, has no direct targeting of parental depression at all. There's nothing in PCIT that remotely looks like depression therapy. But yet, routinely, across multiple studies, parents get less depressed. And again, we're not talking about suicidally depressed, major depressive disorder, but we're talking about clinically significant, what we would think of as moderate depression. Responds very well, even though there's nothing in the treatment that actually directly targets that. Generally, a lot of these models have beneficial impacts in multiple domains. And I think this is important to consider when you're thinking about, well, if this is a multi-problem family, do I really have to prescribe or build into the service plan some sort of treatment or program for every problem I identify? So here's just for an example from the PCIT literature. It's very clear that PCIT improves child behavior problems, oppositional, defiant, other kinds of inattentive, disruptive behavior disorder types of problems. It also tends to reduce the rates of future parent-to-child violence. It improves the behavior of non-treated siblings in the same family. So basically, the kids don't have to, other children in the family don't have to receive the service directly in order to benefit from it. It improves parental depression, equal or better than randomized addition of other mental health services. It also improves not only the behavior at home, but it improves children's behavior in school, which is a totally different context. So you can see improvement in multiple kids and in the parents in multiple domains of violence and behavior problems and other kinds of things from one treatment, including areas which were not targeted. I'm going to give you an example of this, I'm going to talk about this, the rising tide phenomena. This is a new study that we're just beginning to analyze data from. It's a study of about a little over 2,100 parents who were in a home-based family preservation program in Oklahoma. And we tracked a number of things: parent-child relationships, family problems, the level of conflict or interpersonal conflicts with other people outside their family. Those of you, many of you here work in child welfare related stuff. So you know that a lot of the families that are in child welfare, often their lives are ridden with conflict. Not just within the family, but I mean the neighbor, the boss, the extended family. There's all kinds of interpersonal conflict, very high levels of it, including partner violence. Parental depression, a mental health problem, the sufficiency of basic needs, the extent to which the basic concrete needs were being met in the family, the degree of social support, both within the family and outside the family. So again, we measured a lot of change over time with families in these services in multiple domains. Now, those of you who know anything about family preservation will know that some of these are things that are targeted by family preservation services, like, for example, sufficiency of basic needs is directly targeted by those services. Parent-child relationship is directly targeted by those services. Social support is not directly targeted. Parental depression is not directly targeted. Extrafamilial conflict is not directly targeted by those services. Essentially what we found, I'll have to show you the diagram here. I'm just going to show this diagram because it took me a while to draw it, basically. Basically what we found, we used an approach, isn't that cute? This is basically sort of a second-order parallel growth model. Essentially what it does is it tests the extent to which the rate of change, the slope of change over time, is parallel between different types of problem areas. What we found was that basically not only was everything, the rate of change in everything was correlated with the rate of change in everything else, but that basically this is a statistical model, this particular structural model was the one that best fit the data out of all the models that we tested. And this has, I don't know, it looks like a baseball field, doesn't it? But essentially, what we found was that the thing that best fit the data would be that there was sort of a global level of where you started out, that's the I over there, the intercept, and there was a global rate of change, that's the S over here on the end, that's a slope. That basically, change tended to happen in these families globally, not so much specifically. That when one thing got better, other things tended to get better, whether they were directly targeted by the intervention or not. Now, we began to look at this global rate of change and what kinds of things tended to predict it and what kinds of things tended not to predict it. And the number of additional services, now this was a reasonably intensive service. The home visitors would be out at least once or twice a week. So this was not a minimal service. 6 months, once or twice a week in home. Primarily bachelor's level home visitors. And they were using a structured model. So this was not necessarily just ad hoc. The number of additional services that they referred a family out to had no relationship to the rate of change. If they referred the parent to mental health services, the rate of change was impaired. Not just that people with more problems tended to be referred to mental health services, they were, but that the rate of improvement over time was actually reduced when they added mental health service. So again, we see sort of the phenomenon, not just that a rising tide can raise all boats, but that certain types of services, when they're added in, tend not to further your goals. And I'm not suggesting that if someone is suicidally depressed or psychotic, that they don't need mental health services. Obviously they do. But there was a very high number of people who got referred for mental health services, and they weren't all those who had serious, a lot of them had moderate level problems at most. So what's the kind of framework that we might think about for some of these services? Well, one of the things, this has come out in some calls we've had in early meetings of this task force. One is, I think, the importance of assessment and picking a focus for services. And assess things that are clear, objective, and child welfare relevant behaviors and goals. Child welfare relevant, I think, means things that are relevant to the safety and well-being of children, not necessarily are every single problem under the sun that a family might have. Now, if people want services that maybe don't directly address the safety of children, certainly they should be able to get them, and maybe child welfare should facilitate that happening. But, the mother needs to go to psychotherapy to resolve her own trauma issues. Probably is something that's not highly child welfare, not child safety and child well-being relevant. One of the things that I think is fairly concerning in this is that the current assessment paradigm that is often used in many communities, I'm not sure about here, but in a lot of communities, is that assessment consists of psych evals. And psych evals are a pretty mixed bag. I mean, have you ever read one of these things? Would it make you want to go out and get one for yourself? Not me. They tend to be, they can tend to, well, shall we say, they're not always strengths-based. They tend to make people sound pretty bad. They tend to, identify a lot of problems. Not all of them are necessarily child welfare relevant. Sometimes they do a pretty good, I've read some really good, really helpful psych evals that have been done. I've also read some, mother has issues with basic trust and how she, blah, 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 the psychobabble kind of stuff. Not necessarily helpful. In the research that's been done with child welfare workers and particularly with judges, and people have said, how helpful are these things to you? If you're a psychologist who does psych evals, you probably would not be real happy with that consumer satisfaction that's been reflected in a lot of that research. Many judges find them distinctly non-helpful in child welfare cases, simply because they have lots of psychobabble and lots of things about issues and other things like that, and they're not directly relevant to what the courts or the child welfare worker is concerned with, which is, give me some priorities, give me some needs, give me something that's really doable, some objective goals and some other kinds of things like that. So, I think we have to think about, you have to probably know who you can refer to for some of these evals, or we have to begin to think about how to set up systems within child welfare, kind of like we currently do with structured decision making and structured safety assessments and other kinds of things like that, to begin to assess and identify needs. And I'm going to talk a little later, but this is not really rocket science, because every family is different, everything is individualized, but let's face it, the needs that families have are usually ones we've seen before, and there's not an infinite number of them. In fact, as an analog of this, in the state of Michigan, they were trying to revamp their public child mental health system. And they were looking at bringing in evidence-based practices and all this kind of stuff, and they thought, well, man, if we're really going to meet the needs of all the kids coming into our system, how many of these evidence-based practices do we need? We probably need 30 or 40 of them at least. That's going to cost a fortune. It's going to be very difficult. How are we going to keep the workforce in place to do that? Well, they actually began to do assessments and structured assessments of the kids who were coming into their system. You know what they came to the conclusion? They could basically cover the needs of about 90% of the kids coming into their public mental health system with 3 evidence-based service models. They picked parent management training, which is a treatment for behavior disorders across ages, cognitive behavioral therapy, and trauma-focused cognitive behavioral therapy. They figured that basically between depression, trauma, and externalizing behavior problems, they pretty much covered about 90% of the kids coming into their system. And I think a similar thing holds true with a lot of the families and kids coming into child welfare. So we don't need to really pick an infinite number of evidence-based practice models to be able to cover a lot of the cases, especially if you set priorities. And then the other principle is triage. I'm going to talk about this a little bit later with regard to chronic cases or treatment-resistant cases. The triage principle, one of the core principles of triage is that you pick intervention targets that you think you can do something about. You pick things where you think your intervention can actually matter or deliver. So you don't expend precious resources on things that are unlikely to change or unlikely to get better. And I think this is probably true in child welfare as well. So, for example, there are a lot of things that respond pretty well to services. Child behavior problems responds very well to evidence-based services. Parenting, as we've demonstrated, responds pretty well to evidence-based services. Parent-child interactions can respond fairly well. Drug addiction, it responds, but it can take years. It's a process. It's not something you're going to throw an intervention in and expect that at the end of 6 months, we're done. It's often a lengthy process with relapse along the way, and it may be entirely impervious. So there's some things that actually I think can improve, will improve, you can expect them to improve, and other things not. And so the triage principle suggests that you put the bulk of your resources into things that can and will improve. And then you match, as we were talking about different EBTs. The other thing I think within the evidence-based case management framework that's a core principle is that it is the quality of services, not the volume of services, that is the emphasis. That a smaller number and a lower dose of higher quality services probably will yield better results than a volume of service delivered at a higher dose over time. Fewer cooks in the kitchen. This doesn't mean that you give up on family group decision making or systems of care or wraparound, but fewer cooks. For example, if you do MST, which is a pretty well-established evidence-based program, how many cooks are in the kitchen with MST? One. There's one therapist, one service provider who handles everything with the exception of psychotropic medication. And I think the emphasis would be on using the purchasing power of child welfare and the reimbursement power of child welfare to create a demand for evidence-based treatments and to make sure that there are support services to get the evidence-based treatments delivered. For example, one of the things we've run into in implementing evidence-based treatments in child welfare service systems is you can implement a relatively high quality, probably higher cost parenting model like PCIT in an agency, but then what you find out is, well, there's no support for transportation, there's no support to get kids out of foster care transported to the session, it's difficult to get parents to come to the session. So often, you know, what we saw in one of our implementations is that the system spent a vast amount of money getting the providers trained, getting the service set up, getting it implemented, getting the quality improved, and then we overlooked spending the relatively smaller amount of money in support services to make sure that people actually got there and got the service. So I think one of the things we have to think about is we may need to think about reprioritizing some of these support systems to actually, if we're going to do smaller amounts of services that are higher quality, it becomes increasingly important that people can actually consume them and that they get there and get them. Well, what would kind of the menu of services maybe look like? Probably the most common service in child welfare is parenting. I think there's a lot of good reasons for this. I mean, after all, how can you talk about child abuse and neglect without talking about parenting? It is parenting. Maltreatment is essentially dysfunctional parenting. It's the single most common child welfare service. If you look at the NISCAW data set, it's a little over half of all families in child welfare get services. And by the way, most of those who don't get parenting, a lot of those are families that aren't getting any service at all. Some people would say that, you know, the problem is not what we're carrying on about, which is too many disorganized services, but the problem is actually a lot of families aren't getting enough services at all. I would argue that these are two sides of the same coin. That when you have these multi-component, comprehensive, largely unfocused service plans, that they consume resources, and particularly when there's an absence of support services like transportation and other kinds of things like that, that they consume resources, and then you have the phenomenon of there's these long waiting lists to get into services, and it's difficult to get people in. That basically the fact that there's not enough services and that there's this ideology of providing comprehensive services are actually two sides of the same coin. They may feed each other in a way. So, parenting, around half of all families. The studies that have been done to date suggest that with the non-evidence-based parenting models, there's really little evidence that families benefit from them, but there's strong evidence that families in child welfare benefit from some of the newer evidence-based treatment models. I'm going to show you some data on a new study with PCIT here in a little bit. And there's lots of focal problems that these programs address. They improve child behavior problems, they improve parenting discipline skills, they improve the quality of the parent-child relationship and attachment, and they reduce the levels of future parent-to-child violence. All of these are child welfare relevant outcomes. Lucy was talking earlier about our PCIT study where we reduced the rate of future physical abuse from about 50% to a little under 20% using PCIT. This is a new study. This was a randomized trial. We just finished it. This is a manuscript that's going to be going out probably for review fairly soon. This was a follow-up study of our original trial. This study is different. None of the treatment here was done in the university setting. This was all done in a field setting with agency therapists actually at a very low resource community-based agency. I mean, this was literally an agency that had to rely on part-time staff, very low budget. One of our research assistants had to go out there and lay carpet on the weekend so they'd have the room set up in time to start collecting some of the data. And the roof was leaking. And this was a very low budget community agency. And all of the treatment was done by the therapist in that agency. They were trained up, half of them were trained up to do PCIT. The clients were randomized. This was a study we picked absolutely. We ended up getting the worst child welfare clients in the county into this study. The participants in this study had an average of 6 prior referrals to child welfare before they came here. So they were on average on their 7th referral into child welfare. About 75 to 80% were below the poverty line. The median family income was $900 a month. Just try living on $900 a month. The most common reason for interruption of services was parental incarceration. Depending on how you define it, around a quarter to a third had clinically significant depression. A very high number had a history of drug or alcohol addiction. 75% had all of their children, not just one child, but all of their children placed in foster care at intake over time. Most had had some history of having at least one child placed in foster care in the past. So these were deep-end child welfare clients, and they were randomized. And so this was a population, actually, when we ended up getting this population, it was more severe than we really wanted in the study because we were pessimistic that we would have any ability to impact the future child welfare recidivism of this group of parents at all. And to our delight, it actually emerged. This is in the survival, basically the lines, this is a plot of the number of cases that had re-referrals over time. So the more the line stays up, the better the outcome, the more the line drops down. I don't know if you can see it here, but these lines are dropping down to around at about 900 days of follow-up. About 60% had a future report down here, and up here we're up at only about 30% having a future report. So basically we were able to cut the future referral rates in half. So this was a fairly optimistic finding with this. So if anyone ever says, well, these evidence-based treatments, they only work with cherry-picked clients, you can say, but I've seen some data. suggest that it is possible to get results. And this was, by the way, the top line. This was PCIT combined with a motivational enhancement intervention. That's the combination that we used in our first study, and that's the combination that worked out the best here. So we recommend combining those two together. What was I going to say about this? Oh, the other treatments that did not perform as well, some of them were PCIT without the motivational intervention, but the standard care was a parenting program that was far more involved, had lots more sessions, involved working on developing empathy for children, worked on understanding how your own history, your own parenting connected to your current parenting. It was a much more in-depth, much longer term, required many more hours to deliver, and didn't work well. The PCIT up here was 12 to 14 sessions. So even with this population, we're seeing that, in a way, less is still more if it's the right treatment model. Home-based family preservation services are kind of another staple. The problem is there's not really a great evidence-based model for home-based family preservation. There's some promising models. Not all of them have the best track records of success and benefit, but not all bad either, and it's an area of significant ongoing work. One of the areas where intensive family preservation models have a good track record is on preventing removal and preventing out-of-home placement of children. It's fairly clear that they can accomplish that reasonably well. In terms of reducing long-term recidivism, that's a little less clear, but it's an area of some active development, and they focus on basic caregiving skills, which is an important target. The other thing, I think, if I was to pick 3 services, besides a good parenting model, a good in-home family support or preservation model, probably the other would be more trauma-focused CBT models for kids with internalizing problems like depression or PTSD. And there's good evidence that these are very effective. Probably the most developed psychotherapy models for kids are TFCBT. And I think probably everybody here knows a lot about that model since it's been researched here and implemented here quite a bit. It is not typically in child welfare systems, it is not equivalently implemented across maltreatment types. If we look at children in child welfare and their level of need for some sort of service like this, typically for physically abused children, neglected children, and sexually abused children, their rate of impairment runs around 40%. So about 40% will have a significant need for some of those kinds of services. If we look at who actually gets them, well, 80% of sexually abused kids get referred for some mental health service relative to their 40% level of clinical impairment. And about 10% of physically abused children get services relative to their 40% level of impairment. So you see that, if anything, sexually abused children possibly may be a little overserved, physically abused children may be a little bit underserved by a lot of these kinds of models. What about treatment-resistant cases? I'm going to show you some other data here before we kind of go to the questions. But are there any cases that this paradigm of evidence-based case management and use of evidence-based treatments, are there any cases where this may not work out very well? I think there are. And that is cases that are relatively treatment-resistant or chronic kinds of cases. If any of you have been in an airport recently, like I have, you probably walk around and you see a lot of people with the frequent flyer tags on their luggage, right? How many of you have a gold or a platinum? Silvers, I don't count. Silvers don't count. Gold or how many of you are gold or platinum? Lucy, I know you're platinum.
I've fallen off the wagon.
You've off the wagon. Okay, I see 2 people out of this audience who are gold or platinum. If you go to an airport, how many people do you see there with the gold or the platinum? A lot. Why is that? Well, they're chronic flyers. If you go into child welfare, you see the same thing. A lot of people come into child welfare, they receive some sort of service, they leave, and they never come back into child welfare again. But chronic, frequent flyers in the child welfare system tend to accumulate, and they tend to be served over and over. That's why I was kind of impressed that we were able to see results with people who had an average of 6 prior referrals. Those folks had been through 6 previous parenting programs, probably. So they tend to accumulate, they tend to be served over and over. And we began to ask the question of, is their response to service any different than anybody else's response? So what does their response to service look like? And what does it tell us about what their needs are from an evidence-based perspective? I have to put up another diagram. This one took me even longer to draw. Oh, there it is. This is the statistical model we ran in this particular study. Do we have a pointer? I'll just talk about it. Basically, this is what is called a growth mixture model, except it's built on top of latent difference scores instead of intercepts and slopes. But essentially, this looks at general parent functioning across a number of variables at baseline, post-treatment, and follow-up. This was the same 2,100 parents in family preservation programs. And we essentially construct oh, thank you. I'll point to this one here. These are 4 variables which were, I think, child abuse potential inventory, parental depression, basic concrete family needs, and what was this one? Oh, social support. Same things we talked about earlier. And each of those kind of creates a latent variable of general functioning, and then each of those creates a different score of change over time, and we build in the usual things that correct for biases in different scores, like relationships with past levels of functioning, and allow for autoregressive pathways here across the change over time. And basically what we end up with are these initial level of problems, and then up here at the top level, a change score baseline to post-treatment, and a change score post-treatment to follow-up. And then we classify those. Essentially, this procedure identifies different change trajectories. So we don't just look at the average change of the average person over time, but essentially we look at what are kind of the patterns of change that we can fit everybody into the best. And it turns out like this. We essentially identified 5 different change trajectories, 5 different ways that people respond to services from baseline to post to follow-up. And starting at the bottom, we see the bottom pathway of change is people who had relatively lower levels of general problems. They showed maybe a very, very slight improvement, and they kept that up. We feel pretty good about these folks at the bottom. They didn't have extremely elevated levels of problems to begin with. They didn't get worse. They maybe got a little bit better, and they stayed that way. So the people at the bottom, the dashed line, we feel pretty good about them. Then we have the people who had, you see the ones with the squares and the dashes? That's class 2. We feel real good about that group. Those are people that had high levels of problems to begin with. They got better, and they stayed better. This is what services are supposed to be about. You want the bad news? That was only 10% of the cases. Then we had a very small group, that's the solid line, that started out with low problems and got worse and stayed worse. The good news is that was a very small group. Then we have the 2 in yellow. One of them was a group that had kind of a reasonably high level of problems. They responded to service and they got better. And then as soon as services were over, they got right back worse again. And then we have the group that was the highest level of problems, and they basically didn't get any better, and they stayed that way. They were chronic, high levels. Essentially what we've identified here. And by the way, both of the 2 groups in yellow, they tended to be the chronic cases. The more previous referrals you had, the more likely you were to fit into one of those yellow treatment response pathways. So essentially, what we learned from this is that there's two groups of chronic cases. We have one group that gets better, and then as soon as services are over, they don't get better. They get worse, they relapse. We have another group that's just high and non-responsive. Now, what that might suggest about what these two groups need probably are very different sorts of things, because with one of them you might think about some sort of maintenance or booster for the group that relapses, and for the group that's high and stays high, there's really not much point in doing more services because they don't respond to services. This is a group that you might think more about harm reduction rather than intervention and response with a lot of those kinds of cases. The bad news is this high group, high and unresponsive, was 22% of the total cases, and it was the majority of the chronic cases. So we're seeing basically two groups of chronic cases, one of which we might begin to think about booster kinds of services for, and the other of which we probably should think in terms of harm reduction. One of the things that this suggests is that for a lot of these kinds of chronic cases, that child welfare is really not the system to serve a lot of these kinds of cases. Child welfare is inherently a service episode or an episodic type of service model. People come in, they get a service, they leave, and then you sort of rinse and repeat, right? Over and over again. That's the way child welfare is. That's not the way you manage a chronic condition. So you can imagine that if we were managing, let's pick a chronic condition. Diabetes is a chronic condition. You have diabetes, you come in, you get insulin, guess what? Your situation improves. Great, you're done. You don't have to take insulin anymore. That wouldn't work out real well. Chronic conditions typically are conditions that require maintenance and stepped care, or they require, another example of a chronic condition that requires harm reduction is, for example, heroin addiction. There's a certain number of folks who are addicted to narcotics that are intervention resistant. Their addiction is just, they're just simply unlikely, at least in the short term, to give it up, to be able to give it up. So often what kinds of services do we use for folks in that situation? Well, we use needle exchange programs. We use other kinds of programs. We use methadone maintenance, other kinds of things like that, basically to sort of keep the worst parts of heroin addiction from happening. We try to reduce, we don't try to eliminate the addiction, we try to reduce really the really negative consequences of it. That's a harm reduction approach. Both of those approaches require something vastly different than I think child welfare systems are able to provide, because child welfare is episodic. So episodic models really are a mismatch with chronic conditions or with relapsing and unresponsive types of conditions. So by definition, our unresponsive cases, those are the yellow cases that were high and stayed high. They don't respond much to services, so we pretty much can forget about throwing more services at them. But they may be helped by more stretched out monitoring, management, step care, harm reduction. And the relapse cases might be ones where we might think of using booster approaches. There's a lot of questions about if we were to think about serving these cases from a case management, a case planning perspective, what kind of services would we think about? We might not think about them within child welfare. Child welfare really is too much hooked to an episodic service model. But there's lots of other places where things like that might be able to happen. And one of the ones that I think we're considering currently is primary care as sort of a home for some of these types of models. We run a pediatric clinic for kids in foster care. I understand there's one here too. It's called Fostering Hope Clinic. You know, everything has to have a name. So Fostering Hope, I thought that wasn't too bad. So it's basically pediatric primary care for kids in foster care. And when they go into foster care, they come in, try to get all their background records and do various workups and make sure that their health care needs are met. And there's a psychologist and a social worker and a pediatrician attached to the clinic and so forth. I was talking to the primary care pediatrician who runs that clinic the other day, and she had an interesting observation, which is that a lot of the kids who come out of foster care, they go home to their parents, and they keep coming into this clinic. The parents keep bringing them in. And she was asking the parents, don't you know this is the foster care clinic? I mean, you come here by nose, your kids have been taken away from you, kids have been in foster care and stuff. Oh, yeah, but that's fine, we don't care. And what she's found is that a significant number of kids in the Fostering Hope Clinic, their parents, their biological parents, will continue to get their health care needs at that clinic as long as Medicaid will continue to pay. And they'll do it long term. It's a significant number that do that. And so this has started us thinking that maybe for some of these kinds of unresponsive cases, or cases that we might think of as needing booster or as needing maintenance and monitoring and stepped care or harm reduction kinds of things, that maybe the place to build a home for these is in primary care. There's some other options, possibly some other places, schools, other kinds of places where people gather naturalistically. I'm not sure child welfare has the answer to this, but if we think a little bit outside of child welfare, we may think of some systems to address some of these needs. There's a lot of other questions that might emerge, which is obviously nobody wants to volunteer to be in child welfare indefinitely. How would we engage parents in these types of systems? It would probably be a voluntary thing. How would we get parents to want to be involved, make it something that would be help that feels like help and that's beneficial enough that parents would want to have their kids involved in it, and who would pay for it? In many ways, if we root it in primary care, it becomes tied to the entire national health care debate that we're currently having. There has to be some way to pay for long-term primary care for parents, the majority of whom are probably living below the poverty line, and to stay engaged with those systems long-term. There probably has to be some way to pay for it because, as you all know, kids who are in foster care are automatically Medicaid eligible, at least in my state they are. And as soon as they leave foster care and go back to their parents, they may not any longer be Medicaid eligible. And so this all gets tied into the whole national health care debate on how we will pay for this. But that's probably, I think, one of the promising directions that we have for chronic cases. I think that's my last, that's my last slide. So we have 10 minutes, more or less, for questions at this point. We ask people to save questions to the end. So if you have a question, please use the microphones at the side.
The first one is, I noticed on the in-home model that you guys have kind of designed over there, expands beyond the 20 sessions kind of maximum that you like with the evidence-based services. Can you just tell us some of your thinking about why you kind of supplemented that model with some extra sessions?
There were two models that we used that I presented data on. One was PCIT, and that basically was a 20-session model. It was about 12 to 14 sessions of PCIT, 6 sessions of motivational interviewing, so it summed to 20 or a little less than 20. The home-based model, this was a model that was originally developed by the state, and they wanted it to be longer term, and it is longer than 20 sessions. The fundamental model that's being used is the safe care model in that one. The safe care model by itself can be delivered in somewhere around 18 to 20 sessions. And the state added a lot of stuff on top of that. Frankly, if we ask the child welfare workers why they want more than that, their answer would be, we like having eyes and ears in the home. So I think probably the biggest rationale for extending beyond that was not so much a clinical one, but it was that it was for the sake of monitoring, particularly monitoring family reunification. I think we could, in all honesty, I think we could get just as good a results with shorter term.
Okay. All right, so that was a good answer to my first question. Second one is, I like the thought that you had about structured decision-making with regard to assessment and determining what services are appropriate. Do you see a place for norm-referenced tools in assessment?
Yeah. Part of the issue, in fact, I was just answering an email this morning. Our state child welfare system is looking at using trying to select a norm-referenced instrument to assess children and their mental health service needs. And it's a little difficult because they're often expensive, they're proprietary, the cost is high, there's qualifications required for who can administer them and interpret them. It's often very difficult. So the problem, I think, is not so much their utility, but it's finding an instrument that matches the context, the setting, and who's going to be using the instrument. We've made use of some depression screeners and some substance abuse screeners in child welfare. These are very short, typically 10-item or less screening tools that the home visitors will administer to parents, and then if there's a score beyond a simple cutoff, they refer for further assessment. So, I think these are useful. The feedback we've gotten from them is that the workers like them and the home visitors like them because it helps them to be able to determine when they need to refer for further assessment and when they don't, and what type. So we've typically used those. The more extensive kinds of tools that are often norm-referenced, things like the CBCL or the BASC or the things like that, I think you run into a lot of cost issues and a lot of interpretive issues and things like that. And they're frankly more complex and difficult to use.
I just wondered if you'd speak a little more to the motivational enhancement or the motivational interviewing match that you did with PCIT because of the lines, because I'm very interested in engagement, and I think we talk a lot about that. So.
Yeah, there's some interesting findings on that without getting too esoteric. I think the motivational interviewing component achieved two things. One is it improved retention in the services, that the people who got it were more likely to finish the parenting program than those who did not get it. That was one thing. The other thing I think it did is it quite possibly may have improved the use of the skills once people left the sessions. Now, the interesting thing in PCIT, everybody learns the skills in PCIT, and everybody learns them about the same, whether they get the motivational interviewing or not. So, what we see is that, at baseline, everybody's skills are, parents' skills are all over the place. They range a lot. They have a lot of variability. And at the end of PCIT, they funnel right down. Everybody's at criterion. And this was true of about everybody. I mean, we had virtually no variability at post-treatment on how well parents learned. They all learned the skills. But those that got the motivational component, I think were probably able then to implement the skills, were more motivated to use the skills, and they had lower recidivism. One caveat, it does appear that the motivation was a key component of making things work. But the one group that may not have been so true for was people who were already motivated to begin with. Now, we didn't have a whole lot of those, in all honesty, but there are people who come in who are already motivated. And I think some of the literature would suggest, and our findings would suggest, that if you do motivational components with people who are already motivated, it's maybe not a good idea. So if I was going to be implementing the motivational component in a real implementation, I would probably do it on a much more individualized basis, which is how people typically do motivational interviewing anyway. We did it in a group setting simply because our comparison condition was, so it was much more a research design than a clinical decision, the way we did it. If I was going to do it clinically instead of in a research context, I would do it individually. I would do an assessment for motivation coming in. If people were already motivated, I would say, let's go straight to PCIT. And if they were not motivated, then I would build in some of the motivational stuff up front.
I'm curious about your 22% of non-responders. And do you have any wisdom or insight, or can you point to any research about what does reunification look like in that situation, and how do you make that judgment? Especially when you talk about chronic substance abuse, is there a line somewhere where like X amount is okay and reunification's helpful, as opposed to keeping the family split apart and what that does to attachment bonds long term to harm for the child?
It's a good question. I wish there was an answer to it. I'm not sure. most of these families got reunified. And our data, at least with this system, basically suggest that the reunification decisions were based more on whether all the boxes in the service plan had been checked as opposed to objective assessment of risk. So in other words, if we look at the variables that predict risk of reabuse, those are not the same variables that predict whether there's a decision to reunify or not. And I think other folks have found similar things too. So it's a complex decision. It's not quite as simple as, I mean, we do our research on things like chronicity and risk of a future report and everything like that. But you know, as those of you who have any familiarity with child welfare data know, it doesn't always contain very good markers of severity or harm to children. So I can tell you about the risk of recidivism, but I can't tell you whether it was a really horrible recidivism or a relatively light one. And you know, there are families in child welfare, and I think a lot of these families you were asking about, the high chronic non-responder families, are families like this. They're primarily chronic neglect families. In all honesty, the odds are 80% or higher that they're going to be back in child welfare within a couple of years, probably for a neglect report. But you know, it's usually not something that's so egregious or horrible or awful that people start thinking about terminating parental rights right off the bat. It's usually the kind of cases where, and I don't mean to, you know, lessen the concern about the kids, but it's cases where it's low grade but chronic neglect. You know, people are not raping and torturing the children, but they're not really taking good care of them either. And that's a chronic situation. And I think from what I've looked at in the data, that would describe a lot of those cases.
Well, that really rings with me. So, like in that case, like let's look towards the future. How would you address that social issue?
Again, the thing we're toying with, the idea that I hope we can develop and maybe get a little data on, is one of linking those families with some long-term monitoring, stepped care, harm reduction. You know, maybe something anchored in primary care, because it's not. I don't think it's realistic to say child welfare should keep that case open indefinitely. You know, child welfare should hang on to this case for 10 years. Well, you know, the next thing you know would be going from child welfare workers having caseloads of 30 or 40 to child welfare workers having caseloads of 100, which would be impossible to serve. So I mean, I think we have to probably some less intensive but longer term type of service system for those types of families. I'm currently thinking of primary care. If anybody has any ideas other than primary care for where to house that, I would love to talk to you about it.
Okay.
I have a question about substance abuse and treatment and such. Substance abuse treatment seems to be one of the interventions that we say go back and do it every time until it works. You know, so if they go through, we have this paradigm or this continuum from detox, inpatient, outpatient, aftercare, and they kind of plug in and go through. And if there's a mess up, you go back, and it can get repetitive. And I've had a number of clients who will say they get kind of programmed, and I've had some treatment providers say the same thing. This person's been through the program once, twice, maybe more, and they get all the classroom work, so to speak, of a treatment program, and now it's that self-motivation piece. They just have to put the steps on the ground. And I was wondering if you have any research or knowledge for us about, you know, is there a time when, you know, referring them back to substance abuse treatment is just a repetitive use of a service, it's not really going to be the effect. There's some other way to either motivate or just monitor whether they're going to actually put the sobriety with the recovery.
It's a chronic relapsing condition. Mm-hmm. And probably one of the areas where I think we have reasonably good data these days is on the long-term longitudinal course of addiction and how people interface with the treatment system over, I think at this point there's some folks that have data that extends out, beyond 25 years longitudinally. And my sense is what emerges from that data is that there's often, some people achieve stable, long-term sobriety after the first episode or two of services, but there's a lot of other people who basically drift in and out of sobriety and in and out of use, and then come back into services, and then exit out of services, and maybe you're sober for a while, and then relapse again, and then come back into services. One of the things that people think from looking at that data is that simply because someone has relapsed and maybe had services lots of times in the past is not an indicator that services will be of no value this time. In fact, some people think that there's actually a cumulative benefit of services over time, that each time you get them, actually you get a little bit better. I'm staying in a hotel right now that is 100% smoke-free, only in Seattle. It'd be 100% smoke-free. But, I used to smoke cigarettes. I used to smoke a lot of cigarettes. Lucy and I used to smoke cigarettes together quite a lot. And, I can tell you, if someone says, did you quit smoking cigarettes? And my answer is, oh yeah, lots of times. But how long was it between when I decided, I really shouldn't smoke these things, and when I really finally, sort of quit smoking? It was a long time. And I picked it back up and then quit, and picked it back up and quit several times. And I think it's the same kind of thing with any addiction with folks. So I personally, I don't have any problem with trying to motivate folks to get back into treatment if they've had a relapse, and to not give up. Try it again. Every time you do it, maybe you get a little better at it and stuff like that. And I think there's some data to support that works out for a lot of people. Now, one of the problems with child welfare a lot of people have talked about is that the timetable for that and the timetable for children's safety needs is not always in sync. So you have to make tough decisions. Yeah, I think we are at the end of the time. But so if you have a question.
First of all, I will suggest that you add pediatric dental clinic to the pediatric medical clinic, to places where you can make a change. But I was curious about your family case study in the beginning.
Yeah.
What happened and were you able to make an impact?
We'll see. I think they go to court again for a review sometime real soon.